Welcome and thank you for joining our World Stroke Day community conversation. I'm Julie Tristan from Y98's The Wake Up with Brett and Julie. First and foremost, we hope you and your families are very healthy. A quick housekeeping note to our participants. All participants will be in listen-only mode, so no video. Click chat at the bottom of your screen to activate the chat. If you want to engage with the other participants, make sure you type your question in the chat before you hit send. We will be saving time at the end for some questions. Feel free to put them in the chat throughout the event and then we'll come back to them later. We will be recording this presentation. It will be available post-event for all to share this afternoon. Over the next hour, you will hear from 3 local stroke experts from BJC Healthcare. We like to thank BJC Healthcare for their support of the American Heart Association here. You've enabled us to continue to serve the AHA's mission to be a relentless force for a world of longer, healthier lives. The American Heart Association is deeply concerned about the public health crisis facing our country. The top priority regarding coronavirus is the health and well-being of all individuals and their families today and in the future in every community. Well, today it's World Stroke Day, and we are excited to be here today with this incredible group of panelists to explore the latest advancements in technology to diagnose and treat stroke patients and answer any questions that you might have out there today. So let's meet my esteemed panelists today. First up, Dr. Ford. Dr. Ford is an associate professor of neurology and radiology with tenure at Washington University School of Medicine with subspecialty training in vascular neurology. Dr. Ford specializes in stroke in the young adult population, sickle cell disease, and dementia due to cerebral small vessel disease. Dr. Ford cares for stroke patients in the emergency department and inpatient stroke service at Barnes-Jewish Hospital and the outpatient stroke center at Washington University. For the past 15 years, she has led a multidisciplinary effort to grow the acute stroke infrastructure at Barnes-Jewish Hospital to ensure rapid and safe stroke treatments within the early hours after the stroke occurs. She is director of the stroke section in the Department of Neurology at Washington University School of Medicine. Dr. Ford leads an NIH-funded research program with a goal to understand and find new treatments for inherited and sporadic cerebral small vessel diseases. Welcome, Dr. Ford.
Thank you for that introduction.
Dr. Adeoye is the BJC Healthcare Professor and Chair at the Department of Emergency Medicine at Washington University School of Medicine in St. Louis, Missouri. Dr. Adeoye is also the Emergency Physician-in-Chief at Barnes-Jewish Hospital. Dr. Adeoye is an accomplished researcher with over 150 indexed publications in PubMed, and he currently serves as lead PI of an NIH-funded phase 3 acute stroke clinical trial, as well as serving on the editorial board of Stroke Journal. His research accomplishments have garnered a national and international reputation. Outside of his faculty duties, he founded a medical device company using innovative technology from his very first research grant award and serves as the Chief Medical Officer for Sense Diagnostics, Inc. Welcome, Dr. Adeoye.
Thank you so much for having me. I should say, and I'm not going to take too much time, I'm very excited to be here. I've been in St. Louis 9 months. I've been in St. Louis 9 months, and it's my first AHA event. And so I spent a lot of time at these sorts of events previously. So I'm very excited to be here to have my very first one in St. Louis. So thank you again for having me.
So welcome. So excited to chat with you today. Next up, Dr. Chatterjee is an attending interventional neuroradiologist specializing in treating stroke using minimally invasive image-guided procedures and the latest technological advancements. He is board certified by the American Board of Radiology with additional subspecialty certification in neuroradiology. Using experience from his NIH-funded research, he has also helped develop a mouse model for medulloblastoma. How did I do with that one, Dr. Chatterjee? Okay. At St. Jude Children's Research Hospital. More recently, Chatterjee has focused on utilizing advances in brain and cerebrovascular imaging technology with minimally invasive treatments for patients suffering from neurovascular disease. Welcome, Dr. Chatterjee.
Thank you so much for having me. It's a tremendous honor to be here with my colleagues and the hosts. Thank you to AHA for doing this, and thank you to the participants for all your time. Anyone watching this, for the time that you're spending learning more about this, so we can help to improve stroke access and care.
Thank you so much. Well, thanks for taking time today to help us understand more about stroke risk factors, warning signs, treatments. We have some questions that came in before this call that we would love to have answered. If you have a question, please type it in the chat pod and we will get some answers for you from our experts as well. So let's get started with just a very important first question. What exactly is a stroke? Are there different types of stroke? Dr. Ford, would you like to take that one?
Absolutely. And thank you, Julie, for that wonderful introduction. And yes, so a stroke, and this term is used a lot and sometimes not in the correct way, but I hope by the end of today, we'll have a good understanding of what a stroke is and many other things about a stroke. But when we say stroke, we're talking about the brain. And so this is why I have this visual up. I hope you can see it, but it just gives you a picture, a schematic of the brain. And it's like you're cutting through from one ear to the next and looking at the brain from the inside straight ahead past the eyes. And so a stroke is where obviously you have a problem going on in the brain. It's sometimes called a brain attack. And the key thing that alerts us to stroke usually is that it's all of a sudden and something that happens. It can happen upon awakening or when someone finds someone, but in general, it's something that happens very quickly. And so a stroke, some important things to know about stroke right off the bat is that it's in the top 5 for causes of death in our country. And it's also the leading cause of disability, loss of independence, which is, the reason why I think it really warrants so much attention and understanding. Affecting about 800,000 people per year and 130,000 deaths per year. One of the key things to know and why it's important for everyone on this call to help spread the word is that only about 1/3 of people know to call 911 when they're having possible stroke symptoms. And so that's why we need to get better about educating the community about what a stroke is, what we need to do about it, and how to act quickly. Important language for stroke, some terminology that is helpful to know is that the majority of strokes are called ischemic, and that's about 80 to 90%. And about 1 out of 10 times, it's a hemorrhagic stroke. So an ischemic stroke is what we have the picture of here. And that is where you have and these blood vessels are very tiny that go to the brain, only a few millimeters in diameter. And the blood vessels that carry blood and therefore oxygen, which is required for the brain to stay alive, these blood vessels, one of the blood vessels becomes blocked. And so it becomes blocked with a blood clot. And that blood clot can come from either the heart or some other part of the body and travel up to the brain, or it can actually be inside the blood vessel where we have narrowing often due to cholesterol buildup, or also called plaque or atherosclerosis. All of these terms mean that there's a blockage in the blood vessel in the brain, and at some point it just closes off, and that's when the brain doesn't get the blood flow, the brain doesn't get oxygen, and then we have stroke symptoms that alert us to a stroke. And these stroke symptoms are mean that the brain isn't working correctly, and we'll talk more about that. The other type of stroke, which is the minority, so that was an ischemic stroke where there's a clot, there's a blockage in the brain, preventing blood oxygen to the brain. The other smaller group but equally important, and what can be even more deadly or disabling, are the bleeding type of strokes called hemorrhagic. So 10% of cases are hemorrhagic, and that means often a tiny blood vessel in the brain has burst and ruptured, causing bleeding inside of the brain, which can have very significant effects, but presenting similarly often with the same types of stroke symptoms that we'll talk about. So we have ways to determine if a stroke is the bleeding type, hemorrhagic, or ischemic, the clot blockage type. But as a patient, it doesn't matter that much. The important part is to alert yourself or your family or friends that they're having a possible stroke and to seek medical attention very quickly. So those are the two categories. I will also just mention that with the bleeding type of stroke, it encompasses a large group of types of stroke that could be due to many different causes. And that's what we might be able to hear more from Dr. Chatterjee about, as far as the different types of vascular malformations or aneurysms and different things that can put one at risk for a bleeding type of stroke. But it's the minority cause. Thank you.
Thank you so much, Dr. Ford. That was pretty amazing to know all that stuff. Well, we do need to also, like she said, happens quickly, top 5 causes of death. So we need to know what the warning signs of a stroke actually are. And for that, I'm going to go to Dr. Adeoye. Could you explain that to us a little bit? You are muted right
now. If I could find my mute button, I would do that. Yeah. Is everybody able to see my spot a stroke screen? Dr. Ford motivated me. I thought, oh yes, the picture is indeed worth 1,000 words. And so if I were to have one thing that everybody takes away, and I'm not sure who's in the room, but from a community awareness point of view, and to Dr. Ford's point about, from a patient's perspective, we can talk about what a stroke is, and we'll talk about what we can do just as a means of educating everybody. But from my perspective and from a patient and the community's perspective, what I want us to take away is this fast lingo that this is something that the American Stroke Association promotes, and that I think all of us should keep an eye out for. And that is for the F stands for face, which is a facial droop. The A stands for arm, which is arm weakness, and that can also be leg weakness, of course, but for the purposes of knowing what we're talking about here, for the campaign, we use arm weakness. The S stands for speech and speech difficulty, and that can be either slurred speech or all of a sudden not being able to speak, right? And so the combination of either slurred speech or difficulty speaking, and if you have any of those, you don't have to have all three, any one of those is enough for you to say, okay, it's time, and the T stands for time, and time to call 911. And so if I were to have anything that we want to highlight, that is a message that we carry, to Dr. Ford's bullet point about 38% of people being aware, the problem with that is as soon as we're doing educating, we need to start educating all over again. And so the charge for everyone on this call is to not just walk away and retain this information for yourself, but to disseminate, talk to everyone, tell everyone you know, make sure everyone you know knows the fast warning signs for stroke and knows to call 911. And in so doing, hopefully we can make a dent in the numbers that Dr. Ford just showed us.
Well, Dr. Adeoye, what should you do if someone near you is showing some signs of a stroke?
I would call 911 immediately. There's a tendency, I would say, and again, I'm not sure who's in the room, but there's a tendency to want to call my daughter, usually not the son, who's typically unreliable, forgive my sexism. But there's a tendency to want to call my daughter, to want to call my doctor, to want to, pack a bag, to want to get my phone charger, to want to do whatever all else before you go to the hospital. And I would just make the case that we call 911, we come as quickly as possible, There are interventions that we will talk about that can reduce the disability. So any delay in calling 911 is increasing the likelihood that we keep the disability from the stroke. And so please call 911 immediately.
Okay, that's right. Got to remember fast, facial drooping, arm weakness, slurred, difficulty speaking, and then time to call 911. Very important things to remember. Thank you, Dr. Deolier. All right, well, now it's go back to Dr. Ford. We want to talk about who is most at risk for a stroke, Dr. Ford.
Yes, so absolutely. There are some key, what we call risk factors for stroke. And the most common ones are a few medical conditions that I have to say are often unrecognized or underrecognized. And that can be because these risk factors start to develop at a time that most people are very busy going about their lives and taking care of their families and children. And so these risk factors are important to be identified by your primary doctor, but also as a patient or a family member, you can think about this even before your primary doctor may be able to catch it. And so the key risk factors are high blood pressure, high cholesterol, and diabetes. So these are very important things that need to be picked up, and they can be picked up by doing a blood pressure measurement in the office or doing a blood pressure measurement at the grocery store or at home if you have a way to measure it. And they can also be picked up by a blood test. But the important thing to know is that these risk factors having them will not necessarily make you feel bad in any way. You will not know that you have them unless you go to the doctor and ask about them and say, can you please check me for these? And many doctors will check for them anyway. Many people do have a family history of having these risk factors, but just because your parents don't have them doesn't mean that you don't have them. They may have been unrecognized or not diagnosed in your family members. So I really encourage everyone to be proactive about checking on a regular basis for these. The other parts are just common sense, healthy lifestyle, which certainly can be challenging with regard to how busy and chaotic some of our lives are. But things like bad habits, we all know what they are: smoking, overusing alcohol, drugs. These are all things that will set a person up for an increased risk of stroke. And then the other healthy lifestyle points are exercise and diet, because those things certainly can set us up for being more likely to have high blood pressure, high cholesterol, and diabetes. So we can help mitigate those to some degree, not completely, but to some degree, by having a healthy lifestyle, meaning eating sensibly, and having a regular activity a few days per week where you are able to have aerobic activity for about 20 minutes or more. So these can be challenging in our lives today, but really important to help work on them early, because after 20 years of having high blood pressure, then it's harder to go back and to reduce that risk.
I think that's a really good tip. Go to the grocery store, get your groceries. You always see that machine there, and you just sit down and put your arm in the machine and take your measurements or pressures or whatever it is.
Yes.
Go buy your bread and go to that machine. Done and done. All right. Well, we do need to talk about some treatments that there are. There are some major medical treatments for stroke. First, we're going to have Dr. Adeoye talk about, it looks like it's TPA. Is that what it's called?
Correct,
Little
yes.
T, big PA. I don't know if that's some doctor lingo over there. I just talk on the radio for a living. I don't know.
Yes, so I can very briefly talk about there's two approaches. There's medicine and there's procedure. And I suspect that our Chatterjee will talk to us about the procedure. But from a medicine point of view, I think Dr. Ford described this best when she was giving us the explanation of a blood clot type of a stroke. And then there's a bleeding kind of a stroke, right? And so from a blood clot perspective, the medicine that we use to treat it is a clot buster, right? And so if a blood clot is plugging off a small blood vessel that is then causing the deficits and the disability that we're seeing with the stroke, the way we treat it is a clot busting medication. The clot busting medication isn't perfect, but it increases the likelihood that we can get back to minimal disability 3 months from now. And as alluded to, it's not a perfect medication, but because it doesn't work well sometimes, and certainly because some clots are just too big to be digested, chewed up by the clot buster, we also do a procedure depending on whether that's amenable to intervention. And so those are the two treatment approaches that I want us to keep in mind: is a clot buster medication, which is time dependent, going back to the 911 issue. The sooner we do either of these interventions, the better people tend to do. So it's really important that we get there as quickly as possible in order to get the treatments that are available as quickly as possible.
Good advice. The T in the FAST is very important. The time to call 911. So got to remember that one for sure. Now, Dr. Chatterjee, we're going to have you come on here and talk about what is the endovascular medical treatment for a stroke.
Yeah, so this kind of takes the next step of what Dr. Adeoye was talking about in terms of treatment. And this is, we're talking about the strokes where you've got a blockage in the blood vessel. And, there's medicines that you can do to clot bust and try to break those open. And then there are mechanical ways of going in and trying to open those blood vessels up. So I'm what's called an interventional neuroradiologist. I work with a big team that includes people that are endovascular neurosurgeons or interventional neurologists. So a lot of different people work in this field, but we go in through the blood vessels. So whether it's the radial artery in the wrist up here or the femoral artery in the groin, and we take, Dr. Ford was talking about small blood vessels in the brain, we take even smaller catheters, which are small tubes, through those blood vessels, and we use X-ray guidance to take those catheters to the blockage point in the brain. And then we have various tools that we can use to try to pull that clot out. So it's basically glorified plumbing. We're going in, we're trying to suck out whatever's causing that block to restore blood flow to the brain where it's been blocked and what's causing that ischemic stroke. It's a very exciting time in this field because it's only been 6 years that we have, in the last 6 years, that we have evidence that this actually works from a mechanical standpoint. So since 2015 is when we really had the opportunity to start doing these and have really good options for mechanically lysing. And that was in 2015 that we got evidence that it works within 6 hours. Even more exciting in 2018, or just as exciting, was that we could do this safely in some patients up to 24 hours later after they present with their stroke. But the important thing here is, and you'll hear this repeatedly from us again and again, time is brain, time is brain. When you've got a blockage and your blood is not getting to a portion of the brain, it's like suffocating yourself in that portion of your brain. The longer it's being suffocated, the worse the outcome is. So even though we can safely do these procedures in some patients up to 24 hours later, the faster they get there, the better. And so the most important thing for anyone on this call is that, and anyone watching this, is what we keep repeating again and again, is use your most powerful weapon. If you learn to identify a stroke, use this cell phone that you've got, make a call. If it's your friends, your loved ones, or more importantly, a stranger that you've never met before, and you identify a stroke in them and you can get them to the hospital in time, you could be the most important person that they've ever met. So we all have the opportunity by learning about this to get people the appropriate care they need. We're getting more and more exciting tools to be able to treat stroke, but it all still relies on getting there fast enough.
And that makes sense. And I like how fast is what we're using to remember the different signs of the stroke and to get there fast and remember the T, time to call 911. All right, well, Dr. Ford, I know you talked about this a little bit earlier, but it's always a good reminder. Tell us again what you can do to prevent stroke.
Yes, exactly. It does overlap with what we just talked about, and in that, the key to preventing stroke, and this is for most people, there are certainly rare causes of stroke that can happen that are difficult to prevent or to recognize that you have that risk factor. But for most people, being able to treat and manage things like high blood pressure, high cholesterol, and diabetes and to take make the diet changes, exercise, and to take the right medications to help mitigate and minimize those risk factors. So your blood pressure, when you take it, and you may need a medication to control it. When you take your blood pressure, then you have a normal value. And so I encourage everyone, even people who have no history of high blood pressure, to invest in a blood pressure cuff that you can buy on Amazon for about $30. And I think the arm ones are the best. And to just have it in your house. If there are, I would encourage people to try to take it, once a week, and maybe it's once a month if it's fine. And the targets, you'll hear different targets from different doctors, and I think that can be frustrating to patients. But in general, if your readings for that top number, the blood pressure has two numbers. You hear the normal is 120/80. But really, when we get concerned for a consistent blood pressure that the top number is 140 or higher, once in a while it's okay, but if it's consistently on that top numbers in the 140s or higher, that would indicate that you need to talk to your doctor about what you can do to lower it back into the normal range. Eating lower salt can help with blood pressure, and exercise, weight loss can help, but don't wait for those other changes that you want to make in your lifestyle to talk to your doctor, because in the interim you may need to be on a medication, and some people need, because they've inherited it, they need to be on 3 or 4 medications. And that, I think both ways, strategizing to use your lifestyle changes and medications if needed, is really key to, and doing it, identifying it in the 40s, which seems young. We're all feeling healthy often at this age, but needing to identify it early and treat it early, so you can put that stroke, prevent it, and move it from affecting you at age 50 to happening way later in life if you've actually been treating it. So those are the same risk factors that you would want to make sure are treated, avoiding those bad habits like we talked about, and then trying to incorporate healthy lifestyle, whether it's doing the stairs instead of the elevator, any sorts of things that increase your activity, increase steps, aerobic activity. These are all sensible things that will help you in the long run.
Always that healthy lifestyle. It's never just eat pizza and ice cream all the time. You gotta always eat healthy. So Dr. Ford, if somebody does have a stroke, and can stroke patients fully recover?
Oh, yeah, absolutely. So there's a whole spectrum and that's what I love about my job. So I see stroke patients, from very mild, and you've heard of the term probably TIA or mini stroke, where the symptoms resolve within 24 hours, all the way to the devastating strokes that lead to death or lead to someone having to live in a nursing home after their stroke. Fortunately, it's a relatively small proportion of strokes that have that very bad outcome. And that gives a lot of patients who do have a stroke or a TIA the opportunity to help prevent another stroke and to help and to work on recovery. But of course, what we prefer more than anything is prevention of a first stroke. And so that's why I think what we have already been talking about is actually more important. But for stroke recovery, and we really rely on the patient to be motivated, their support system, their family, to help them through stroke recovery period. For many patients, it's a very several months to year recovery. It's just very variable across patients, and as far as the duration that's needed for recovery. And then we really rely on the therapist. So our physical therapists, occupational and speech therapists really are the ones who, in addition to the patient and the family, who get all the credit for recovery after stroke. So if you've had a family member or know someone who's had a stroke and is having difficulties and hasn't been put in touch with therapists, that still can happen. People can fall through the cracks when they're discharged from the hospital. Then definitely, encourage them to seek out their local therapist to help them get back, adapt to the new deficit and get back to their daily life as best as possible. We also need better treatments for stroke recovery. And so that's a huge area of research that is needed to help with the brain recovery after stroke.
Well, that kind of leads me on to my next question. Are all stroke patients eligible for the same treatment? Dr. Ford, if you could talk to us about, it's called wake up stroke, someone who wakes up with stroke symptoms.
Yeah. So this is one of the really cool things about stroke care that Dr. Chatterjee was alluding to. And that was that expansion of our treatment window from 6 hours to out to 24 hours. And it doesn't mean the patient, or we can delay care to that long if the patient comes in early. It means that we have an opportunity for some patients to treat out to a longer treatment window. And this is based on technology and new imaging techniques. So there's new imaging techniques with CT scanning and new imaging techniques with MRI scanning that allow us to select certain patients who otherwise wouldn't have gotten a treatment and now can get a treatment based on the results of these imaging tests. So it's not uncommon for a patient to come in with stroke symptoms and undergo a very quick battery of brain imaging tests. Usually the CT scan is coming first, and there's not just a picture of the brain, but an understanding of the blood flow patterns in the brain to see where the stroke is, how bad is that brain tissue in need of blood flow, and what region is it affecting. And so based on these numbers these factors that we see on the imaging, we can help decide if a patient may still be eligible for a treatment, like either the medication treatment or going in and doing using a device to pull out the blood clot. And so for the part that I've been involved in a lot of research in, and now actually is part of our clinical care, is using MRI scans to help find, and this is back to wake up stroke. So about a third of patients will wake up with their stroke symptoms. So, most patients have their symptoms right when they're going about their daily life, and it's an all of a sudden change. But for about a third of patients, they wake up and they realize, oh, I'm not moving one side of my body. I'm not able to talk. My speech is slurred. And for those patients, still coming into the hospital very quickly is important, because we can do both CT scanning and consider a treatment based on those results, but also a brain MRI to help time if the stroke just happened right before the patient woke up, or did the stroke happen hours before, right after they went to bed. Because if it happened right after they went to bed, then the brain tissue has already died and there's no benefit, and there's some risk to giving the medications. But if the stroke happened right before waking up, and we can determine that based on the brain MRI findings, then the patient is eligible for a treatment and may benefit from that treatment. So that's been a very exciting part of the stroke clinical research kind of field that I've been able to be a part of. And this has been really exciting to see us able to expand the amount of patients who can be treated who are coming in with stroke symptoms.
Now, I know you were talking a little bit about an MRI. Is that the same as an HMRI, or what is that?
Yeah, we have all these terms, it's just a huge amount of medical jargon that we use. But yeah, that is called hyperacute. So we have this term acute, which means the stroke just happened, meaning within 24 hours. But when we say hyperacute, it means the stroke happened within a few hours or within minutes. And so we're able to, because we've worked out protocols within our emergency room, working together with radiology and emergency medicine and neurology, we've been able to allow to bring patients to the MRI scanner very quickly and do a very quick MRI to determine if that patient is eligible for a treatment. So that's what we call hyperacute MRI, which not a lot of hospitals have. Barnes-Jewish, we have that ability here and have really worked hard to make this protocol possible. We hope that this type of scan that can be done very urgently can be expanded to more hospitals, and that hopefully will happen with time.
And Dr. Chatterjee, if you could tell us a little bit about something called a CTP for stroke patients in treatment.
Yeah, absolutely. So to extend the discussion a little bit about what Dr. Ford was talking about, you know, there's all these different imaging tests that we can do now, and imaging is evolving. Like all these different sides of stroke care are improving in parallel. One of those things is imaging with something called CT perfusion. CT perfusion is what Dr. Ford was alluding to, where not just getting a snapshot of the brain at once in the blood flow, it's looking at how fast the blood flow is getting to different parts of the brain. So that gives us some idea of which parts of the brain have already sort of suffered so much injury that they can't be recovered. And then it shows us certain parts of the brain that can recover. And based on that imaging study, we're able to determine whether a patient is a good candidate for more aggressive treatments like the things we do where we try and remove blood clots using devices. Now, CT perfusion is very exciting. CT perfusion and MR, hyperacute MR, Dr. Ford was talking about, are two of the tools that have helped make those 24-hour extended windows possible, because now we can select patients who are able to safely get these treatments and restore blood flow. So the idea behind all this is we're trying to find which patients are best for what type of treatments we do. And devices, all the tools that we have are constantly improving. The imaging that we have is constantly improving. And almost more important than all that is our systems of care are improving. Now that we know that these patients can get these treatments, we're learning more about how to create hubs and networks, and having all these different physicians and all these different complex systems in the hospital working in a streamlined fashion together is revolutionizing our ability to care for these patients. So all of these devices, tools, imaging tools are part of what allows us to improve care for people that end up having a stroke.
I mean, that's good news that things are getting better. I like to hear that. So can you also, Dr. Chatterjee, talk to us about the treatment for a hemorrhagic
stroke? Yeah, absolutely.
Hemorrhagic stroke. Yes.
Yeah, and before I answer that question, yeah, your thing about good to hear that things are getting better. I think it is good to get a kind of a global perspective that stroke outcomes are getting better, and in the US, people are living longer after having a stroke. They're recovering better. There's still a long way to go. There's still a lot of socioeconomic discrepancy in access to care. There's a lot of discrepancies in between first world and third world nations in terms of access to care and outcomes. So there's a lot we can do, but it's important to take a look back and see how much progress has been made so as not to get discouraged about the future. Now, to get back to your question about hemorrhagic stroke, so yeah, Dr. Ford had mentioned, you've got two categories of stroke. One is the big 90% ischemic, where you're not getting enough blood flow to the brain. The other is the 10% where you actually have a bleed. So something breaks in that tubing system and blood is getting into places it shouldn't get into. Those typically will present in a very different way, which is a severe headache. Classic med school lingo is worst headache of your life, thunderclap headache. Those kinds of symptoms can be an indication that there's a bleed in the brain. That is a very serious sign, and those patients typically have a much more tenuous course. There are things that we can do about it if they get to the hospital again quickly, because time is brain. If a patient gets to the hospital quickly and they can get stabilized, we can go in and try and identify where that bleed is, what's causing the bleed, and potentially try to stop that from the inside or with surgery, or helping patients get through that period of time afterward, which is kind of a tenuous period of time. So again, if you know someone, or you have a thunderclap headache, or see someone that falls out, again, call 911, because getting access to a comprehensive stroke center where they can get treated for that is the most important thing to getting a good outcome. So.
Thank you so much. Well, let's talk about some new stroke treatments that are on the horizon that I know my panelists are excited about. Let's first talk about TNK, a new clot-busting drug. Dr. Ford, Dr. Deoye, I know you guys know about this. Dr. Deoye, haven't heard from you in a while. Tell us a little bit about TNK.
That I am happy to. I will point out that, as with a lot of things that we do in stroke, we sometimes learn from heart attacks. And so TNK is actually not new, but it has the advantage of a single bolus as opposed to given the bolus and then running a little bit of medicine over an hour, which is what we currently do for TPA. And so there's also some suggestion that it may have fewer complications, even though those data aren't as robust. And so the combination of, okay, it may have fewer complications, plus it's about the same overall, and we can give a single bolus, makes it very attractive. And what we learned, especially in the past year, was having that drip over an hour put nurses and doctors more at the bedside over that hour in the world of COVID, as we're all trying to navigate and manage how we take care of COVID patients who came in with strokes. And so TNK garnered a lot of interest over the course of the past year, even though the momentum had already been building even before the past 2 years, a year and a half or so. And so altogether, TNK is a very attractive, exciting new, not new, but new option for us to treat stroke patients with, and a lot of places are adopting TNK.
Dr. Ford, can you tell us a bit about StrokeNet trials? It's a network of 500 hospitals for small and large clinical trials.
Yeah, and I think the others on this panel should talk about it too. We're all involved with this StrokeNet, and we are one spoke of a whole network of centers. But for our region here at Barnes Jewish Hospital, WashU, we are a hub for our smaller network of research trials. So the neat thing about StrokeNet, the goal is to conduct it's all about stroke, improving the care of stroke patients through acute interventions, stroke prevention, and stroke recovery. So there's a group of new treatments that are being tested for all of these purposes. And the idea is to be able to reach the entire country in a way. So that's why it's organized by having kind of larger academic centers be a part of StrokeNet, but each center has other spoke hospitals that it works with to help make sure that these treatments are being tested across the country. And so we're very proud to be a StrokeNet center here and be able to conduct the cutting edge clinical research that is being done to really help move the field of stroke care forward. So we have more treatments to offer patients and to improve the patients' lives even further. But I would also love to hear from Dr. Dayoe, who is the principal investigator of one of the StrokeNet trials for the United States, which is called MOST, and I'll let you take it from there.
Thank you, Dr. Ford. And I will go back to my heart attack analogy, right? A lot of what we do in stroke, sometimes the brain is a little more finicky and a little bit more particular, and so it works easily for the heart. And then we have to sort of pay close attention to make sure we don't make it have any complications or do any damage when we apply it to the brain. And so one of those is adding medication to the clot buster. And so adding an antiplatelet drug or another blood thinner to the clot buster. And so over a period of about 10-15 years, we gently added smaller doses to the clot buster and the combination. And we are comfortable. The combination is safe. It looks like it may be working out that those patients who get the combination are doing better than patients who got the clot buster alone. And so we are in the middle of studying that at 110 hospitals of these 500 across the country. And we're hoping to have about 1,200 people participate at Barnes. I can't remember what the exact numbers are right now that have participated at Barnes. Nationally, we have 262 out of the planned about 1,200 or so. And so we are on our way, and if all goes well, we will be able to have an added treatment that makes incremental gains on where we are so far. And to Dr. Chatterjee's point about if we look at it, it looks like we're not making as much progress, and we're all very impatient people. But the goal is to have us do even just a little bit better, and in so doing, have fewer patients with disabilities due to stroke.
Yeah. And just to piggyback on that idea in terms of my excitement for StrokeNet, I think it's incredibly exciting because, you know, we have all these ideas for how to treat stroke, rehab, how to diagnose stroke, and any individual institution to do a proper clinical trial to determine if these things work can take years and years. But now the NIH and NINDS have funded this StrokeNet, 500 hospitals. So these ideas can now get quickly implemented into these clinical trials. And we can, the idea is in much shorter period of time, enroll enough patients to answer those questions quickly. So the idea is, again, to create these networks and get these systems of care in place and systems of research in place to answer these questions quickly so we can make improvements in years rather than in decades. So it's exciting.
Well, thank you so much for all of your information today. Thanks for all the in-depth answers to the questions. We're just going to go to each of you and see if you have any final thoughts you would like to leave our attendees with. I do want to remember fast. That's what you're leaving me with today, fast. Facial drooping, arm weakness, slur, difficulty speaking, time to call 911. I will remember that always. Dr. Ford, any last thoughts from you?
I will say go out or go online, buy a blood pressure monitor and take your blood pressure, write it down. That would be my hope for everyone, or maybe you can share one across your family, or your give one to your parents. Yeah, that will be my homework for everyone here.
Perfect. We love shopping on Amazon, so that sounds like fun today. Dr. Adeoye, any final thoughts from you?
I will piggyback off of Dr. Ford's many excellent counsel and advice as we went through the past 50 minutes, and say, if you have high blood pressure, please don't fight it, right? We all tend to want to be younger than we are. We all tend to want to sort of push it off and not take that blood pressure. I don't like medicine. Who does? Who likes medicine? I don't like medicine, but I've been taking high blood pressure medicine since I was 24 years old because I had high blood pressure. And so if you have high blood pressure, please don't fight it. And I would just, that's, you know, there are many risk factors, exercise and weight and diabetes, but the high blood pressure and getting ahead of that, it's just way easier than anything else that we can target. And so just take your medicine.
Dr. Chatterjee, what would you like to add?
Yeah, full confession. I piggyback off all that again, and you know, take the preventative things that you can do are so important. It's really hard, and I know it's hard to break bad habits, and it's hard to diet and exercise and make those wellness things an important part of life. But you know, I started taking, much to my chagrin, cholesterol medicine because I've got high cholesterol and I couldn't control it, and it's just something we got to do sometimes, and just make sure that you're doing all the preventative things you can do. And the second thing is to emphasize what you had mentioned. Yeah, fast. Time is brain. Take care of the people around you. Be an engaged citizen with the people around you, and identify people that might have a stroke based on the things that you've learned. So.
Well, thank you all for joining us for this important conversation about stroke in our community. Doctors, thank you so much for the work you do to help people. I think that's just so amazing that you dedicate your lives to help others. That's super cool. Know that no matter who you are or where you are, the American Heart and Stroke Association is here to help you through these tough times. Their website is stroke.org and heart.org. They have all your health resources you can share with your family. Thanks to BJC Healthcare for your continued support. That brings us to the end of our conversation today. I'm so excited that we got to chat. I'm excited my dogs were quiet for the rest of the time today. And everybody have an amazing weekend. Have a great Halloween and take care of yourself. Thanks so much. Have a great day.
Thank you very much.
Julie.